Hi, everyone. This is Andrew Cutler with a brief message about changes at the NEI podcast. Our host, Sabrina Siegel, is moving on to an exciting position in the field of TMS research, and we couldn't be happier for her. So what does that mean for NEI podcast? Well, we'll be taking a temporary hiatus over the summer. From July through September, we will revisit some of our most compelling episodes on topics that remain as relevant today as when they first aired. New episodes will resume in the fall, so make sure you're subscribed so that you don't miss out. This summer, NEI Podcast is revisiting some of our most compelling episodes. In today's re-release, Dr. Sabrina Siegel interviews Dr. Anna Ratzliff about improving mental health outcomes through collaborative care. The topic is timely for NEI as we've just launched a new primary care portal on our website to provide easier access to education and resources for managing mental illness in primary care.
I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, we are discussing improving mental health treatment through collaborative care. And I have here with me today psychiatrist Dr. Anna Ratzliff. She is a professor at the University of Washington and co-director of the Ames Center. Welcome, Dr. Ratzliff.
Thank you. I'm really excited to be here.
Excellent. My first question for you is, what exactly is the collaborative care model, and what are the core principles of effective collaborative care?
Yes, it's pretty exciting to talk about collaborative care because it really is a model that I've been able to practice in as a psychiatrist and see the positive impacts on patients, and really them being able to live the life that they are hoping to live by getting their depression or anxiety addressed in primary care, a place that they're often very comfortable coming. This model really started when people started thinking about how could we address common mental health disorders in primary care settings. And that's important because depression is the most common mental health disorder. It's the leading cause of disability in the world. And really thinking about how do we get out where patients are likely to show up, which is often primary care, and really address this in an effective manner. So collaborative care really takes that relationship between a patient and their primary care provider, that often trusted relationship, and adds in structures to organize mental health treatment, and then additional psychiatric expertise from both a behavioral health care manager, that's often a provider that might be a social worker or a nurse that has skills in both behavioral interventions, being able to deliver psychotherapy, but also really helps coordinate the work of the team for collaborative care. And then a psychiatric consultant, a person like myself who's a psychiatrist, who really helps with diagnosis and treatment planning to support that primary care provider in delivering mental health care right there in primary care. And this is there's a couple of key pieces that have to be in place to have this be the model that has been shown in over 90 now randomized controlled trials to be effective. The core things that people really need to have in place is that team. So that core team of a primary care provider or primary medical provider, that person often is doing the prescribing, has a close relationship with the patient, often ends up helping with diagnosis, that behavioral health care manager who's doing care coordination and delivery of evidence-based behavioral interventions, and then that psychiatric consultant who really is going to actually deliver most of their care indirectly. So they don't actually see the patient, but they actually meet weekly with that behavioral health care manager, review all the patients on that care manager's lists that have been identified as needing help, and talks about or helps with the diagnostic assessment and treatment planning for the patients that really aren't getting better on that caseload. So really focusing their energy on the patients that need changes or intensification of their treatment. In order to facilitate that, so that's really the first thing, team-based approach surrounding that patient in primary care. The second big idea is that idea of having a caseload of patients or maintaining a list of patients that is actually available and easily accessible by the team members so that they really can make sure that no one's falling through the cracks. So patients are not coming back in for care. So being really proactive about doing outreach to patients, making sure they get back in for follow-up appointment, get back in and stay engaged in treatment. I think that's really important because often depression gets in the way of effectively engaging in treatment. So having somebody whose job it is, that care manager, to do that outreach and make sure they come back in for treatment, I think is part of that secret sauce of collaborative care. So often people use something called a registry for this function. That can be as simple as a list of patients. There are much more sophisticated registries that are embedded in EMRs or even as standalone web-based applications that really facilitate the work of that team. And so that's the second real principle, is that sort of population health approach, really defining a population of patients that need care and doing proactive outreach to engage them and make sure that they stay in care. And then that goes hand in hand with really the third principle, which is measurement-based treatment to target. And this is really the concept that you're going to be identifying the target for treatment. So in the case of depression, and then thinking about what is a measure that can help whether or not the treatments that you've been offering and working with the patient around are actually getting the job done of getting the patient better. So that means that you're going to regularly re-administer that measure, ideally at times when you'd be making treatment decisions, and then really using that as one of the pieces of information that might guide intensifying treatment, changing medications, trying a different treatment if a patient isn't actually responding to the first thing that you try. And this is a really important part of collaborative care. This isn't just measures kind of randomly, but actually at that time, again, when you're really making those treatment decisions. And this is really important because collaborative care helps, I think, organize the team to be able to do that consistently and well. And I think that's one of the really major drivers of why patients actually have improved outcomes, because we've really organized care to make sure those changes in treatment that need to happen actually happen. So that's really third principle. The fourth principle is really the concept that you're trying to offer patients that whole range of evidence-based treatments in primary care. That means that you should ideally be able to offer both medication treatments as well as psychosocial or therapy treatments for patients. And I think it's really important that one of the ideas is that you are actually making sure that's high quality care delivered. So that's really the fourth principle for collaborative care. And I would say the fifth principle is really being accountable to making sure that this teamwork is getting the job done. So actually having quality measures of both the processes of care and then monitoring, tracking the population patient outcomes that you're getting with the work that this team is doing together. And that's really important because this is leveraging the expertise of a team. This is delivering care in primary care. And I think whenever we're doing something that's a new way of delivering care, it's really important to monitor the quality of that and make sure we're getting the outcomes that we hoped to get. So that accountability, that commitment to continuous quality improvement if you're not hitting your targets, that's really the fifth principle of effective collaborative care.
Wow. Thank you so much for sharing all of that with us. It seems like there are so many important elements there, and seeing how it just all comes together. Related to that, my next question is, what is it that is so unique about collaborative care?
Yes, I think there's a lot of different things that I talked about in that first answer that I think make it unique. I think there's a couple of things that I'd focus on. One is that it really uses psychiatric expertise in a new way. So instead of a psychiatrist actually seeing most of those patients directly, that psychiatrist is really able to leverage their expertise over a caseload or panel of patients in a very specific, organized way. So in this case, it's through the case review process, which I think there's two pieces that are really important. The first part is that they're actually thinking about a population of patients. So 60 or 70 patients that care manager might be following. So that really is thinking about not only the patients who are obviously needing help, but who else is on there that we might not be thinking about. That really proactive way of approaching patient care, which is a little different than traditional practice, where you generally might be seeing the patients that are on your list for the day, right? On your sort of schedule for the day. I think that's a really different piece to that. I also think that I really like the focus on quality and measurement that's part of collaborative care. I think that really provides a lot of reassurance to the people involved in that care, a lot of places and ways to monitor that the way you're organizing care is actually getting that job done, that you know that patients individually are getting better, and that your overall system is getting a high percentage of your population of patients to have demonstrated improvement.
That's excellent. What does research show us about the effectiveness of collaborative care on depression and other mental health conditions? Can you share with us some of the findings from the IMPACT study?
Sure. As I mentioned, there's now probably over 90 randomized controlled trials that have shown that collaborative care approach is an effective strategy to address mental health conditions in primary care and other medical settings. So there really is a robust evidence base at this point that collaborative care works. I think that in those trials, the early trials mostly focused on depression and mostly in primary care settings, and the IMPACT trial was one of the studies. That's still the largest trial to date. There were 1,801 patients in that trial. And what they really showed in that trial is that when you compared organizing care the way I just described it with collaborative care, where you had that team, where you're using a registry, where you're doing regular measurement-based treatment to target, and then monitoring overall quality of the care you're delivering, compared to usual care in the same practices. So in that trial, patients were randomized at the patient level to either collaborative care, where they were supported by the care manager in the team-based approach, or they were supported by the PCP alone, who was allowed to do really anything that they wanted to do for usual care. So in some of those practices, that was referring out, in some that was prescribing medication, and some that was even maybe having a co-located therapist down the hall that was involved in the care of the patient. And when you looked at what the outcomes of those patients in that actual trial, what you saw is that twice as many people improved in the collaborative care arm of the trial compared to the usual care arm. So a little over 40% of the patients were improved in the collaborative care arm, compared to about 20% of the patients showing improvement in the control arm. And I think that's a really powerful outcome, because it means that you really can significantly improve the chances that a patient's going to have an improvement and really likely have a big improvement in their life when you're organizing care in this way in primary care. That trial also showed a couple of other important things. There was good patient and primary care provider satisfaction with delivering care this way. I think there's increasing focus that outcomes aren't enough, that we really have to be thinking about the triple or quadruple aim: good outcomes, provider and patient experience. And then also that in that trial, they went on to do a sub-analysis later looking at total costs of healthcare in the patients that were involved in that trial over the next 4 years. And what they found is that in that trial, if the patient had received collaborative care, though there were initial increased costs of delivering collaborative care, when you looked at the next 4 years, they actually had a total decrease in their overall spending of about a return of investment about $6.50 to every dollar spent. And so that really was an important finding, because it actually showed that if you do address depression up front, get patients actually to improvement, they are going to have overall improved health. And interestingly, most of those cost savings were actually in avoiding physical health, hospitalization. That population was actually an older adult population. And so really addressing depression probably helped their overall health. And that was really what was driving those cost savings. This is a model that really does deliver on that triple or quadruple aim. That's the aspirational goal when we think about healthcare improvements. Since those early trials, there's been expanded populations. So this has been demonstrated to be effective in children and perinatal populations in different conditions. This has been true for anxiety, depression, substance use disorder is a growing body of evidence, bipolar disorder, a growing body of evidence, some early work in ADHD, really expanded to a larger number of conditions, and then to some subspecialty settings like psycho-oncology, cardiology patients as well, diabetes patients as well.
Mm-hmm. Mm-hmm. In the collaborative care model, you touched on this a little bit earlier, but what exactly is the role of the care manager?
Yes, I always like to say the care manager is really the heart of the team. And then that's because I think they really sit it right there in the middle, meeting the patient frequently, really helping to facilitate two functions. One, the care coordination. So making sure that patient has follow-up with the primary care provider when they need it, really making sure that they talk about that patient with the psychiatric consultant and get those recommendations to be implemented. So really doing a lot of that work around that, really proactively doing outreach and engagement of the patient. So that's really their core coordinator, care manager role. And then the second part is that in most of those trials, the care managers also delivered evidence-based psychotherapy. Now, this is psychotherapy that's been adapted to primary care settings. So it's often shorter, low-intensity cognitive behavioral therapy kinds of approaches that have been adapted to primary care. So often these are sessions that might be integrated into their regular visits with the patient, that these might be, for example, 6 sessions of about half an hour, for example. Necessarily long-term psychotherapy, but able to deliver that right there in primary care. So I think those are the two big roles that we often see of the care manager in a collaborative care team.
What is the role of the psychiatric consultant?
Yes, I've touched on that a little bit. In some ways, I think the psychiatric consultants, really their role is to leverage their expertise. So they might help early in treatment with making sure that there's a good diagnosis and talking through that case, looking at all of the data from that patient, really helping to make sure that we have a good provisional diagnosis for the patient, that we can then decide what the evidence-based treatments for that diagnosis would be and make sure that those recommendations get to the care manager and the primary care provider to implement them. And then I think the other thing that I think about is that their role really becomes one of educating the team. And you do that both directly through maybe having a partnership with that primary care practice where maybe you give a lunch and learn or go down and might provide resources or readings around particular conditions that come up in your case consultations. And some of that is actually indirect. So as you write notes on these patients and give them to those primary care providers, you're integrating a lot of why you're making the decisions that you're making to really the best learning that a primary care provider could have to skill themselves up around making diagnosis and making early treatment planning decisions. And when I was in this role, working as a psychiatric consultant a lot, very early on, I often would have cases and I'd make fairly simple medication recommendations that would really be appreciated by the primary care provider. You know, making sure you optimize the dose of an antidepressant, for example. What is the common next medicine to switch to? I would say, though, as I worked with a primary care provider over several years, the consults that came to me became much more complicated. So I really interpreted that as that the primary care provider was becoming much more efficient at doing those first couple of steps on their own without me after we had done them together a few times. And they were really sending me much more complicated, more complex patients. And I think that kind of indirect learning is really a neat side benefit of the role of the psychiatric consultant in a collaborative care team.
Wow, that's great. What are some ways to leverage scarce psychiatric resources through collaborative care?
Yeah, and I've talked a little bit about this and touched on this a little bit. I think one of the main things is that typically a psychiatric consultant would spend about 2.5 to 3 hours per full-time care manager delivering their collaborative care role. So that includes time to actually meet together, time to review notes, maybe some availability for an urgent question from a primary care provider throughout the week. And typically that in that time, they would be able to support a panel of patients of about 60 to 80 patients that care manager might be following.
Oh, wow.
So that means in 2.5 hours of their time, they're really able to leverage their expertise over a much larger population than they would ever be able to do if they were actually to try to see all those patients in person for initial consults and then follow-up care. And so the first thing I think it does is just leverage your expertise through a team. I do think the other advantage is because you're not doing direct care, there is that opportunity to have physical space separations between where the psychiatric consultant is and where that practice is. So for myself in Washington State, which is actually a pretty rural state, I did a lot of my collaborative care from my office at the University of Washington in Seattle, but I could actually work with practices that were an hour ferry ride away. And so that really allowed me to also leverage my expertise over distance, that they didn't need a psychiatrist living right there in their community. And I think that's a really important, that both of those dimensions are an important part of collaborative care and how you might leverage your expertise.
Wow. That's great. Can you share with us some of the step-by-step guide to implementing the core model in clinical practice for collaborative care if someone wanted to try to get this implemented at their organization?
Yes. So in my work at the AIMS Center, which stands for Advancing Integrated Mental Health Solutions, we really work to help promote the dissemination and implementation of the collaborative care model. So this was a center founded by Dr. Jürgen Unitzer, who was one of the original study investigators on that IMPACT trial. And I think one of the things that happened really early after there was such positive findings from that trial is that people started saying, help us figure out how to do this in our primary care settings. And that really led to the development of the AIMS Center. So over the last 15, 16 years, we have been thinking about and helping practices learn to deliver collaborative care. And over that time, we've learned a lot about what it takes to actually be successful in implementing collaborative care. And through that, we have created basically a step-by-step implementation guide that really at a high level actually outlines the core learning that we have of the order and tasks that really need to be done to likely have a successful implementation of collaborative care. So that's available on our website, and I'll talk through it a little bit. We think that early on, that really it's important to lay the foundation. And this is a lot around getting really clear around what are your goals of implementing collaborative care. What kinds of things would you like to see different in your practice if this was successful? And making sure all the key players that would be involved in actually starting to deliver care in a different way are on board and have a shared vision for what that would look like. And I think that's really important because maybe the primary care provider has one idea of what the most important thing is. Maybe it's easy access, that when they have a patient that actually needs to be seen, that somebody can see that patient quickly. That's going to be a really important thing to take into consideration as you build out your workflows, right? Because that means maybe in your care manager's template for the day, there needs to be some access for rapid connection of patients that need that. And so getting that need out on the table really early before you're actually designing the workflow is really important to make sure that everyone's ideas are actually talked about and that you get a shared plan of what do you think is really possible given the resources that you have in the clinic. Increasingly, we also say it's really important to think about sustainability of this program beyond implementation. And that can include thinking about how are you going to capture revenue for the services you deliver. And that has important implications for the kinds of people you might hire into certain roles, especially that care manager role. Different billing options have different constraints around who can be in that care manager role and still be able to bill for the collaborative care services. So we often encourage practices to think about that early before you're hiring people. And the other thing about being clear on your vision is really also that you want to tie the things that you were hoping to do to metrics that you'll monitor for quality, right? So if access is a really important factor for your team, then you want to make sure you have a good measure of access. Is that how long does it take to get to the third next available appointment of the care manager? That could be, or how long does it take to close a referral to to behavioral health services? So those kinds of things can be helpful in actually shaping the metrics you would ultimately use for that accountability component of your collaborative care team. In the second phase, after you've done all that good work, it's really focusing on what are the workflow changes you need to have in place to actually deliver on those outcomes you're trying to target. And really making sure you have all the infrastructure built out. What's your registry going to look like? How are you going to deliver the measures for measurement-based treatment to target? Who are the kinds of people you need to hire, and how are you going to get them on board? So all of those kinds of details around creating that new workflow really happen in the second. The third phase is really training the team and making sure everybody's on board for how they're going to share care. As you can hear from the description, there's a lot of handoffs and coordination that have to happen consistently and well in collaborative care. And people often have to be trained up for their roles, especially anything that's new. Maybe the primary care provider hasn't really worked closely with a behavioral health care manager before, and they need to figure out how they're going to communicate. You need to think about how the behavioral health care manager and the psychiatric consultant will organize their case reviews. Are they going to do that over a Zoom call, or are they going to do that in person? How are they going to make sure they can look at the registry together? So you work through all those details of how to work together as a team. The fourth phase is really actually making sure that you launch your care well. And in those first couple of weeks, you find the patients you need to find to get onto your caseloads, that you make sure that you start working out any wiggles or snafus that come up in your workflow, which inevitably happen no matter how perfectly you plan it. And just really a lot of close monitoring in that early phase to make sure there might be additional training that a team member needs. All of that is what happens basically in that fourth phase, launching your care. And then lastly, you move into a phase of sustainment or nurturing your care. And in that phase, I really think of it as following those quality measures. And then whenever you find something that's not performing the way you would hope it would be, you're going to actually quickly pass through all of those phases again. Is it not happening because there wasn't a shared visit? Is it not happening because there's a workflow change that needs to happen? Is it not happening because there's training that needs to happen? So you'll actually almost re-implement whenever you have a quality metric that's not meeting your standards that you've set as a team.
Wow. That's so interesting. Thank you so much for sharing that with us. And that will definitely be, for our listeners, you'll be able to find this step-by-step guide on the AIMS Center website, and we'll include that in our show notes. But that was an excellent overview. For implementation of the collaborative care model to be successful at various organizations, what factors are needed?
I think that's a great question. And I think it's one that really is at the basically front of everyone's mind right now, especially around where the evidence base, where people are doing experimentation and learning right now. I think the early stages were proving that this model works. And now I think people are really interested in how do we get it working in the real world, which is really around implementation. So there are a few papers and observational studies that have come out that really suggest that there's a few key areas that are important to focus on. I think the first one is really that there is that buy-in, leadership, organizational buy-in, and really clear goals. And that's why I talked about those a lot in that lay the foundation piece. And that there's really a plan for sustainment and commitment to continue to be invested in this program. So I think that's really important, especially early on. I think it's important to think about that there is a real need for resources for what it takes to implement collaborative care, and then also to think about what it needs to sustain collaborative care up front. And you could hear that from all of the steps that I was describing. There's a lot of work in implementing collaborative care early on, and you really need to make sure that there's a clear program manager or somebody kind of organizing the team that's implementing that those steps actually go through systematically, and that there's time for the providers to actually participate in learning about the program and learning their role within the collaborative care team. And then lastly, I would say that behavioral health care manager is a really important part for success. If there's some work that came out of New York State that really said that if that person isn't close to full time in their role, the clinic is less likely to sustain collaborative care. And if they don't build a meaningful size caseload pretty quickly that has good outcomes, the clinic is unlikely to sustain collaborative care. So some of those factors that I was talking about in terms of quality are really important. I think this really comes up, especially when people may have had a behavioral health provider in a clinic, maybe that was working more in a reactive role, being there for sort of crisis management or supporting psychosocial needs. If they're going to be moving into a care manager role, they really can't do that other job too. They really need to have the time to do the proactive types of care engagement that really are what drive the collaborative care outcomes. So I think those are a couple of the areas that we're seeing emerging as being really important for successful implementation.
That's great. Great information. What type of training do clinicians need in order to implement this collaborative care model? Are there specific training measures or courses that they should be taking?
I think that's a great question, and I think that's really one that is evolving. So I think for each of the different provider types, there's probably a different amount of training needed. I think for primary care providers, especially who are delivering care for common mental health disorders, this might be really feeling more comfortable with making those diagnoses and supporting the delivery of the treatment, often being a prescriber for the medications. I think a lot of times they can get a lot of support through their psychiatric consultant as they're working together, but I think there's really making sure they understand the model of collaborative care, that they're still the primary treating provider for that patient in a collaborative care model. That's really important. Making sure they know how all the systems of getting patients to a care manager, how they'll get the information from the care team, those things are all really important. For the behavioral health care manager, I think it's really important that they have both collaborative care management skills as well as those brief evidence-based psychotherapy skills. And that might be new. Not all training programs for MSWs or nurses actually teach those brief evidence-based psychotherapies. So that often is an area where that person may need to do some continuing education. We have examples of training programs on the AIMS website, so that could be a resource if people are interested in that. And then lastly, for the psychiatric consultants, I think this is often a new role for a psychiatrist. They're used to seeing patients directly. So if they weren't exposed to the primary care psychiatry or collaborative care model in their training program, they may need some guidance around how do you leverage your expertise? How do you gain confidence and feel comfortable actually delivering care this way? The American Psychiatric Association has still a pretty robust set of training materials. I was actually fortunate enough to partner with them in my AIMS Center role for a large CMS grant that ended a couple of years ago, where we trained a lot of psychiatrists across the country, and the online training materials are still available from that grant. So I would point people to that, and we can make sure that link is also shared with your listeners.
Sure, absolutely.
And that training is free, so people can, access that pretty easily.
Excellent. Thank you so much. And that takes me to my final question. And you touched on this a little bit, but what program factors are important for sustainability of this collaborative care model?
Yes, I think that, again, as we talked a little bit about implementation, I think this is where people are really wanting to invest in learning and understanding a little bit more about this. We actually, at the University of Washington, I am a multiple PI on a new grant that we recently received to look at collaborative care model for co-occurring substance use, opioid use disorders, and common mental health disorders. And we're pretty excited because one of our goals in this is to actually study more specifically, what does it take to sustain collaborative care once you've implemented it? And we are focusing on the three areas that have really emerged out of our work from the AIM Center. What we have found to be important for people to continue to sustain collaborative care is having those quality metrics and commitment to regularly review your program and continue to do quality improvement when you find pieces, either processes of care or outcomes that aren't meeting your standards or expectations. So that real commitment to continuous quality improvement and really making that just part of the way you deliver collaborative care, I think that's a really important factor. We also have seen a lot of programs, if they really were having one person who was the real champion and that person leaves that organization, sometimes that institutional knowledge leaves with them of how to do collaborative care. So we think it's really important that practices who implement collaborative care really have a plan to manage provider turnover in any of those key roles. How are you going to orient new primary care providers that come into your practice? If you have turnover in your care manager role, how would you train that new person? Can you have a manual that outlines the things that they would really need to do to learn that role? And similarly for the psychiatric consultant, if there was turnover in that role, how would you orient that new person to the way that your team works to deliver collaborative care? So I think really plan to manage turnover, anticipating that that's going to happen naturally can be really helpful. And then lastly, I think financial sustainability. I think if there is not at least some amount of revenue coming in for these programs, it can be really hard for practices to sustain these efforts. I think with that, also defining the value of the collaborative care team broadly within that primary care or other medical setting is really important. So provider satisfaction, increasing access to treatment for a population that you really want to serve in your community, those kinds of things may be important dimensions to also be measuring as far as part of what it means to be a value add program within a primary care practice. But I think anticipating that, planning that, measuring that, making sure you are also thinking about that dimension of sustainability is really important for long-term success.
That's excellent. Thank you so much for sharing all this incredible information with us. I think this is so important, and it's great to get this out to our listeners. And thank you so much for being on our show.
Thank you for inviting me. I'm really excited about people getting engaged around collaborative care, and I do hope that if people are excited about this idea, that they access some of those free resources and that there is, know that there's support out there to actually help you make this transformation happen in your own practice.
Yeah, absolutely. Thank you so much.
All right, thank you.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.